Elective single embryo transfer is the transfer of one embryo when you have more than one to choose from. It's basically a way to make IVF safer. The goal of every IVF cycle is to have a single healthy baby, and single embryo transfer helps us do that. Basically, when you look at IVF programs over the years, the first IVF cycle 34 years ago, it took 100 cycles to get the first baby. So it went from a great experiment to now an excellent way to manage most infertility. And as we've learned how to grade embryos and what makes a normal embryo, what makes a healthy embryo, what can make a person, we've been able to improve the pregnancy rates and increase the chances that one embryo will stick and grow. When you look at single embryo transfer versus, say, dual embryo transfer, what we find is that the pregnancy rate, depending on the study, is either the same or just a tad lower with single embryo transfer over dual embryo transfer. But when you look at the take-home baby rate per retrieval of eggs of a single fresh embryo, and if it doesn't work, a single frozen embryo, those two together carry a higher pregnancy rate and or the same pregnancy rate and are considerably safer. Now, with emerging technologies where we can use genetic screening, chromosomal amplification, to grade embryos, we're better able to even pick better embryos to put back. And for sure, with that technology, single embryo transfer is at least as effective as dual embryo transfer. The goal of every IVF cycle should be a healthy single baby. Without a doubt, the uterus was really only made to carry one baby. When you start transferring more babies and you raise your risk of multiples, you raise your risk of complications, be it to the mother, to the baby, be it short-term just with the pregnancy and delivery, or be it long-term during the course of the baby's lifetime. The dangers of multiple pregnancy are really fairly significant. 4% of all the preterm babies that are born in the United States today come from IVF at a cost, a direct cost, say the mother's cost of the hospitalizations, etc., and the baby's neonatal intensive care unit costs, etc., of $1 billion. So these babies are at higher risk for delivering prematurely, they're at higher risk for having birth defects, they're at a little bit higher risk of having complications during their lives, be it developmental issues, in addition to the stress to the family of trying to raise 2 babies at the same time as well as 1. Then you've got the mom's side. She has a higher risk of having complications in pregnancy, be it prematurity, preterm labor, diabetes in pregnancy, blood pressure problems, requiring a cesarean section, time lost off from work. You also have the issue of trying to breastfeed 2 babies as opposed to 1. So there are a number of reasons why single embryo transfer is really a prudent approach in the carefully selected patient. Basically, single embryo transfer isn't for every patient, and you have to choose your patients carefully to really pick the best group where you have the highest pregnancy rate. So what you want is a patient who's under 35, who has a good prognosis for conception, be it this is her first or second IVF try. A recipient of donated oocytes is an excellent candidate as well. Or say a couple who conceived before with IVF very early in their treatment and want to try to conceive again. All of those groups are really excellent candidates for elective single embryo transfer. ASRM's new practice guidelines for eSET are that you should counsel every patient who's a good prognosis patient under the age of 38 on putting back 1 to 2 cleavage stage or day 3 embryos. And for day 5 or blastocyst embryos, 1 embryo should be put back. An ideal patient for eSET is one who's under 35. It's her first or second IVF cycle. She's using donor eggs, or she's gotten pregnant. The couple is conceived from a previous IVF cycle. eSET versus dual embryo transfer is transferring 1 versus 2 embryos. The problem with transferring 2 embryos is you still carry a very high twin rate. That's especially true with day 5 embryos, where the twin rate with putting back 2 blastocysts is 50 to 60%. When a patient has cryopreserved embryos after an eSET cycle, it raises the odds of success per egg retrieval. So the patient doesn't have to be hyperstimulated again. They don't have to be retrieved again. They can have an artificially timed frozen embryo transfer that's where you create a normal uterine lining and you can time the cycle for your convenience. Frozen embryo transfer cycles now carry almost the same pregnancy rate as a fresh cycle with the advent of improved freezing and thawing technology like vitrification. It's considerably cheaper than doing a fresh cycle because there's no medications involved, there's no embryo culture involved, there's no egg retrieval involved. It's just a matter of thawing the embryo and transferring it. So it really improves your yield per retrieval, which is really what your goal is to try to get as many babies as you can from 1 egg retrieval. Issues regarding the disposition of embryos are very delicate and vary from family to family. What you would like to do is optimize the developmental potential of each embryo, and those issues need to be discussed up front so that you can adjust your stimulation protocol based on how couples feel about extra embryos. But they have a number of options. You can use 1 cycle, 1 retrieval cycle to get multiple babies. You can limit the number of eggs that you work with up front. There are also agencies where embryos can be sent and other couples can anonymously use them to help them conceive a family as well. You know, it's interesting. The barriers vary from country to country and from region to region in the United States. Classically, the barriers are both physician and patient-oriented. Patients want to get 2 babies for the price of 1 and think that twins is just a great way to get things out of the way. The problem with that, though, is that twins are clearly more dangerous to carry and to deliver and much more expensive to raise and riskier for a number of reasons versus a singleton pregnancy. And even with 2 embryos, your risk of twins is going to be anywhere from 30 to 60%, depending on if you do a day 3, a cleavage stage transfer, or a day 5, a blastocyst transfer. On the physician side, the barriers are that physicians think that single embryo transfer will lower the pregnancy rate. And actually, that's not always the case. The majority of the time, it's not. And since doctors are judged by their success rates, they don't want their numbers to look bad and for them to lose patients to other programs. What's interesting, though, is when you look at eSET utilization in the United States, you find that eSET utilization is much higher. And I think we can overcome the stereotype that it's great to put back 2 embryos and twins are a great thing to have with just programs like this, where we use patient and physician education as tools to share the scientific data with our communities.